I want to give a heads up to anyone who is here for the first time. We'll ask you to introduce yourself. And actually, as I'm looking at our group today, we have a smaller number. And also, I don't see new faces, but if we did have new, we might even be able to do some introductions. This is a Zoom meeting. It's being live streamed to the public. It's being recorded. We do that so that members and the public can stay engaged. Please be aware of background noises, mute yourself when not talking. And during discussion times, I encourage you to keep your video on as much as you're comfortable as we get to know each other. Quick reminder that HEART is the team that leverages our diversity to create new solutions so that as we respond to COVID-19, the entire community achieves optimal health and no one is disadvantaged. We are the team that extends solutions beyond public health professionals so that business, government, civic associations, human service providers, and others join with healthcare to change our habits, our ways of doing business, so that everyone gets to have the best health possible. We use data in partnership with the community, the best information available to us, disaggregated by race, origin, and other relevant identities to identify harms and risk, to make strategy, take actions, and measure progress. Today, we're going to do 5 things. We'll welcome new members if we have any with us today. We will have another discussion about our HEART COVID-19 Town Hall or conversation planning. We will talk about some current funding opportunities that could help support health equity. We will learn about the Pandemic Health Navigator program. How is that going? Where is that going? What's the future hold? And then we will also look for a COVID-19 update from the Department of Health. All right, so is there anyone with us who is new? Okay, no, I'm seeing all familiar faces as I look around. And I want to welcome you all back. And, you know, this is my way to segue into what is our first discussion about the town hall discussion. I had a chance to go back and review our recording of February the 25th. That's the day where we spent about 30 minutes talking about what we thought should go into a community conversation. And I'm about to show you on the screen. I'll share my screen and show you how I kind of summarize the results of that conversation. But this is what I want to say. As I got back to that, I realized how much heart is in HEART. I got to listen to everybody again without the pressure of running the meeting and see how much our life experiences are contributing to the discussions that we're having and how important that is to us in representing our communities. And so I was moved by that, and I wanted to say to all of you, thank you for bringing your heart to HEART. So I'm moving us into agenda item number 1, which is the HEART COVID-19 Town Hall discussion. When we last met, we had identified a whole range of ideas that could be covered and a range of ways to approach them in discussion. And I had promised to get a planning committee together and schedule that conversation before this meeting would have happened. And my first apology to everyone is that I didn't keep my commitment to do that. I'm as committed as ever to this process going forward. I think this is a really important tool for us in relating to the community and preventing the harm of COVID. But I wanted to acknowledge that we didn't get done what I had hoped we would after the last meeting. So let me share with you, if I could, my screen and see if I see the folks who are here today are really very much aligned with the folks who were with us on February the 25th. And I want to, are you able to see my screen? And are you able to see it as far down as to maybe our plan 1 and 2? What I'd like to do is give you a moment to glance through numbers 1 to 7 which capture the conversation about the topics we wanted to cover. And then I'm going to scroll down to the bottom half and show you more of the screen to give you my sense of what's our best plan to put that into action. All right.
Chris. Oh,
go ahead, Chris,
I was
please.
gonna say, it strikes me how much things change even from like 2 months ago, 3 months
All
ago.
right, here we go. That is our life. So that raises the question of whether we add or subtract to the list. Let me go ahead and show you then the bottom half and see if that might start to address, Chris, the concern that you raised, and the same one that came up when we talked about it February 25th. It only takes a few weeks for things to change. And I'll narrate these. Given all of the things that we heard about above, the breadth of them, and the way that they're so interlocked and interlaced, these are kind of the 5 points that I come away from that discussion with. We want to take a whole community approach. Our promotion, presentation, and circulation all need to be in the languages of DuPage. We have been English-centric in the way we've presented, and we did provide a Spanish language simultaneous interpretation in January. We can expand that, and we can do the same with all of the promotion materials. The general concept that grew out of last time was that we want to take an open for questions and concerns approach rather than a topic that will have some folks feel excluded or that it might not be relevant for them. So we're responding to the questions our neighbors have, and we're asking for those questions in advance of the session. Third is kind of a derivative of what I heard there, and that is this is a non-judgmental environment. We're responding to the anxieties and concerns of all. A lot of the topics that we heard brought up are what I would consider to be responses to those who are vaccine hesitant. And so it's very important that our environment is one without judgment, and we're taking people where they are. It's an ongoing conversation rather than a one and done. And it features a panel of expertise is available for responding to concerns. And at our last meeting, these are the ones that were kind of popped up at the top. Infectious disease specialist, we want to know about the immune system. Pediatrician, we still don't know for sure what the timing and implementation of the vaccine for under 5s will be. Psychiatrist, Amina, excuse me, Simon, you helped us to understand the way that that affects all of us, even those of us who've not had COVID. Sports physiologist, because of the concerns around myocarditis. Dietitian has become so important for preventing, treating, and recovering. And then the question about the school environment and mental health of kids. That also has to do with the masks issue. So I'm suggesting to you that this is the way that we approach, and that we my anxiety has been around finding a pediatrician who could help us. And I've kind of gotten past that to say, we'll find a way. Let's schedule the time. Let's get the meeting going, and we'll get the right person to step in. Jan, you were with me yesterday in a meeting with the DuPage Early Childhood Collaboration, and with that group of great community leaders, we came up with 3 potential ideas right away, and they've circulated as well. I've gotten 2 more responses, so I'm confident that we'll find people who are willing to step in with us.
And David, I can reach out to the pediatric group at Rush Hospital if you want. I'm sure we can find someone out of that group as well.
Dave, as I look at this conversation on the pediatric COVID immunizations, I think it's an opportunity to address vaccine hesitancy in general with this group, as it, and I don't want that to be the sole purpose, but it is an opportunity to talk about vaccine safety and kind of address it if you have a pediatrician on board and they would be willing to do that, because I think it's something that we're seeing with misinformation out there and just hesitancy. It's maybe not even misinformation, maybe it's just a confidence issue.
Other thoughts on the basis of what you see here?
So David,
yes,
can I add? So I'm just thinking that I don't know how much situation has changed now from last 2 months. So we should definitely update, and we should know what is the current COVID cases, because I saw some news of Pennsylvania. They started mandating masks because of some. So I don't know what's the current situation in DuPage County and in Illinois.
right. So we're going to get a chance later in this meeting to hear an update from Chris. And Chris, I'm really interested in listening, because I'm hearing now there's a variety of messaging coming out of public health entities about what does this mean this time we're in. And once again, health departments are in a difficult spot of trying to get people to do the right thing without being overly anxious and yet being aware. Simon, that's what I hear you saying. We're actually seeing case counts begin to increase. We're seeing changes once again, but there's mixed messaging. What does that mean for us? And that's why I'm so convinced now that a regular conversation with the community like this is what's so important. I heard a public health professional say the other day, it's not about getting the perfect message out. It's about having a conversation. Yeah. So
Dave, we talked about it earlier in the document, but going back to nutrition and building up a strong immune system and doing all the things that also work for other chronic diseases, it's kind of an opportunity to reinforce that too.
Mm-hmm.
Can you guys hear me?
yes.
Okay, good. I have not apparently been able to be heard for the last 10 minutes. Sorry about that. I've been like, why isn't anyone listening? So sorry. A couple of thoughts. Number one, more than happy to find a DuPage County pediatrician, including one that was bilingual, if that was helpful, to participate in a conversation, and entirely confident that that would not be a difficult lift. I definitely favor the approach of having a sort of a conversation with perhaps a bulleted list of potential topics on the materials that were circulated, but also really allowing us the flexibility to talk about what is pressing in the minds of the attendees, and also what is sort of the most current thing, because it is still such a rapidly evolving space. But I find myself thinking that the community is not wholly aware of how low the rate of boostering is. I think that because we have been so successful as a community at getting those first 1 or 2 doses, and that is oftentimes the message that people have sort of held on to. They're not aware of what significant gaps we still have in being fully boosted. And I think prioritizing conversation about waning efficacy of that first round, and also maybe some information to give people anticipatory guidance around what are likely side effects from the booster, responding to concerns, but also assuaging them, I think would be a helpful piece to include.
You
This
know,
is
also,
Karen. I agree with everything. Sorry, Dave.
Go ahead.
I agree with everything that Kara mentioned. And yeah, I'm thinking in particular of one pediatrician who is both who is bilingual Spanish, who had some interest actually in the board, and I know would be very Board of Health. So I know would be very pro-vaccine. So I don't think that's the issue. A concern, as significant a concern as is the evolving scientific understanding and guidance. So this idea of absolute protection, or if you're safe if you, that kind of thing. I think this is our opportunity to move toward reducing risk conversations. It's also, and Chris will, I'm sure, get into this as we go through the cases, it's becoming increasingly difficult to quantify cases, case rates, positivity, all of that, due to reporting changes. And I don't, although it makes me very uncomfortable from the public health science side of things, I don't think that's necessarily a bad thing, as in the more macro text of this response and recovery. One thing, though, that I think we could continue to really prioritize is around the mental health. People keep, and I'm a little bit more sensitive to the people blaming all of the COVID mitigation strategies on, it's really taken a toll on mental health. The not being in school, the wearing masks, the social isolation, all of that. Well, I think just as important, it's to consider is we've lost 2,000 residents to COVID. People have lost their grandparents and their brothers and sisters and their aunts and uncles. And the issue of grief, 1 million people, it's like 2 9/11s every week that the toll of this pandemic has wreaked. And I don't think we're necessarily doing a very good job of addressing those issues. I even see that internally with staff who have lost a loved one, and they still have to get up and deal with all of this contentiousness around, is COVID even real? And I don't think that we're addressing that too well as a general kind of rule. So, and Chris, I absolutely love the idea of, love that Seattle King flyer, rather than making the masking a political statement, offering another narrative for people to consider, I think is a wonderful opportunity.
thanks. I haven't had a chance to review that yet, but I'm seeing a lot of good feedback, Chris, on that. Thank you.
I also think, and Chris may address this a little bit in the slide deck, because I feel like it came up at our hospital meeting, but there are also sort of the resources and treatments continue to evolve. And as COVID becomes less of a foreground conversation topic in the community, I think people may not always stay up to date on all of those resources. So the idea of being able to talk about test to treat, being able to talk about what is most effective with current variants as far as treatments and what's on the horizon. And then also where it relates to long COVID, to be able to give people some guidance about resources that are available in the community or the region that people may not necessarily be aware of or have been referred to might also be a hopeful and useful thing to touch on.
Very good. You know, I may have said this to this group before. I spent some time working in disaster response before coming to DuPage Federation, and flooding, tornado, hurricane, mostly natural, but also human-made. And in the world of disaster response, there is always this period where the community as a whole, as a large group, experiences some recovery. And all of a sudden, it becomes very difficult to pay attention to the needs of those people who are still impacted by the disaster, still working it, still identifying people who need help to prevent, treat, and recover. And it's a thing in disaster recovery. And my intuition tells me that we've reached that stage with COVID. So it's being more difficult to get people's attention to pay attention. And that's why I'm so glad this group exists, because here we are making sure we're keeping an eye on those people who have experienced harm, and we're going to do something about it, continue to do something about it. Well, let me ask this question. We met for that community conversation in January on a Monday evening at, let's see, that was January the 10th. Maybe it was, that was a Monday evening, and I think we did it at 5 o'clock. And I want to ask the group here if that's a good, if Monday at 5 is a good time, or if we should look at another time of the day or week.
Looks fine for me. I don't know about we had pretty good participation from people. Hard to tell what the best time is, right? But seems like early evening time is probably good to give people an opportunity who may not be able to join during the day.
Seems like
Yeah, I
5
think-
o'clock sort of straddles a line that opens the door for community partners and doesn't close it for people that are still doing it as a piece of their workday. Whereas if you get too much later, you potentially lose one or the other. I'm entirely unclear on the community's appetite for these conversations right now. So I mean, I think you just do it and see whether or not people come, but it does feel like there's enough to talk about that it's worth the effort.
Do we have contact information for everyone who attended the last one? I'm assuming we have an email address. So, you know, is it worth putting out a quick survey? You know, do you still have questions? Here's some of the things that we're thinking about addressing on our next community conversation to see what kind of response you get. As long as, you know, kind of here's our thoughts, and then maybe an open-ended question of what else can we help you with, and then a question of I'm not interested in participating anymore, you know, so that because if even half of the people who participated last time indicate that they, you know, like to participate again, I think it's absolutely worth doing. But if your response rate is super low, then maybe it's something to think about, maybe a different approach.
That's a great idea. We can do that.
If we write the survey in such a way, or perhaps have a slightly different version of it that's targeted to people that didn't attend, but we want to gauge their interest in doing so, that would also be helpful, because I'd be happy to text out a link to Access to Page members, for example, and try to solicit questions, but it might not line up as neatly with the questions we would ask a prior attendee. But it would be helpful, and it would also help us to plan around meeting the needs or questions that people have.
I would add to that to involve our school nurses across the county, specifically because we are looking to inform and motivate parents to have their children vaccinated. And with that, we can also target some of the neighborhood groups as well as the parent groups, and specifically those groups that are attracting our minority populations. But I'm thinking back to a meeting at Edward Hospital did rounding on COVID-19 about maybe 3 or 4 weeks ago now. And Dr. Pinsky was the keynote speaker. And he asked if we being the people in public health, can use this lull in COVID as a time to increase informing people and motivating them to get their vaccines as well as to boosters. I put in the chat the link to an article that Science Direct, I believe it was, published a couple of weeks ago. And I know that we have the anti-vaccine people who seem to be primarily white conservatives. And in this article, it discussed that, and I don't want to say racializing COVID has actually been used as for some people in these groups to not get the vaccine. So at some point, I'm thinking we should consider how do we formulate a message that this should be is an inclusive, a public, a societal, for lack of a better word, project that we need to get everyone on board with.
Yeah, what a line. Here we are, the group that exists because those disparities are there, and we don't want them to be forgotten. On the other hand, Jan, here's the evidence that perhaps when we emphasize the disparities, we're reducing the participation of some members of the community.
Yeah, I've heard that same story, Jan, not that article. So thanks for sharing, but I've heard that reported, and I feel like it aligns with the interest in underlying conditions. Like, well, did that person who had a severe outcome have an underlying condition? Well, that's not me, that's them. That's something else to worry about. And it's like this desire to want to like say, that's not me that's going to suffer these consequences. So I do think finding a way to help communicate risk kind of broadly, like COVID doesn't matter who you are. And the risks are the risks. And certainly some of us are at higher risk based on our social circumstance. And so highlighting some of those things, I do think is worthwhile. Karen's point, 2,000 people across DuPage have lost their lives to COVID, and they are all walks of life.
In that same article, Chris points out that the majority of people who have died from COVID are not minorities. Mm-hmm. Yes, a greater percentage and disproportionate number of minority people have died, but the majority of people who have died from COVID and who are now dealing with long COVID and the loss of quality of life. And this goes back to what Karen was speaking about, dealing with chronic illness. And I'm going to even throw in there PTSD, post-traumatic stress syndrome associated with COVID. And David, thinking back to what you said about coming out of these disasters, this was a disaster that is still sort of smoldering. At what point do we start making a way for these families, these people, to know that there is some help out there for them, some support?
It's 9:30, and I am conscious that we want to, in a couple of minutes, move to our next content for this meeting. And Karen, you asked, do we want to bring this to a point? And when we talk with our audience about it, what's the topic that we're addressing? And I think that I would suggest that the topic that we want to put forward to people is responding to concerns and anxieties with resources and solutions. And those would include, and we can give kind of a starter list of what those might be, but the tone of this is flexible responsiveness to the concerns that are with us now.
Dave, I wanted to go back to some things that Jan had mentioned, and the parallel I'm thinking of right now is deaths from opioid use disorder and overdoses. And what we hear a lot from those families is, they somehow want to remember and have something good come from it. So we've lost a lot of people in DuPage County, more than opioids for sure. So it's not an exact correlation, memorializing and what is putting face to that. What does it look like? What does it mean? What are the consequences of that? Because I think the other similarities are that you do have some PTSD and you do have some overwhelming grief, and hindsight's 2020, have done differently. What could we have done better? And so I'm finding a way I'm thinking of the Tribune when they did a spread on DuPage County overdose deaths way back early on in 2013. And it told stories. So I don't know if we can do that same thing here, but I think really paying some attention to the loss and some of the scenarios and what that looks like is important.
Thank you. And that I'm apologize, Jan, I was moving on quickly to our next, but that's kind of the core of our emotional health right now, right there. And that deserves our attention. And Dr. Esfer, I see your hand up also.
Yes, just two points, David. One is we don't have, data. That's another thing. We don't have proper data which can show that which communities were affected more. Within our clients, we are seeing tons and tons of need for mental health, and we don't have enough support in those languages and in those areas. So that's definitely worth looking at and thinking about. The second thing is, in parallel, I'm thinking that why don't we have another session for kids by the kids, hosting kids and by the kids, and we can record that small session and we can have it on our website where kids can share how they feel and they can open up with their, and we can plan it better, in more detail. But we are talking about kids and how they are feeling and, what about their vaccine? Maybe they have different types of, maybe they are very excited for this summer. What are the summer plans and how they are going to enjoy in this summer? So perhaps we should have something focused for children and by the kids. I am actually back to school program in charge of ICNA Relief. It's a national program. So I'm all about children, always. So, if we want to have something for kids, let's do it by kids too.
Getting lots of hand claps in the chat about that, Sima. And I'm remembering also the maxim from the disaster response world, and that is follow the children. They will lead us through. That's a great idea. So now we want to find a way to put that into action. So let me ask this question, if this makes sense going forward. So we will do a communication with our audience from January the 10th. We'll put out our ideas for a community conversation and frame that with some thoughts about things that we think are relevant. We'll propose, I would like to propose to them a May 2nd, 5 p.m. gathering and get their response on how that would feel for them. I think we're only going to get interest and additional ideas. I think that's what this will do. It will mushroom, and I think that's a good thing. And So I wonder if folks would feel comfortable penciling in 5 p.m. on May the 2nd as a potential conversation resumption date. And I would commit to get this communication out to our audience early next week, and also get a planning group together to talk about the logistics for making this happen. And we have a couple of offers in the room here today about a pediatrician and a psychiatrist. And I would encourage us to reach out to those folks to test their interest and in doing this with us, period. And then second, testing availability on May the 2nd at 5 p.m. But that was a lot in one. Let me get your feedback.
David,
Only to say, oh, sorry, go ahead. You first. I'll go after.
so May 2nd would be the holiday, Eid holiday.
Oh my goodness, we can't do it then. Thank you.
So either before that or after that.
All
It
right.
would be great to do it after that. I think we could use a little more time. At least 3 weeks would be great.
And
But
I was just
hard.
going to say on the pediatrician front, I'm happy to search, but sometimes it can create a little bit of offense with people if you ask them and then they say yes, and then somebody else has already asked someone else, and then we have too many providers instead of too few. So maybe if there's someone else who is interested in reaching out to someone, I'll happily step back. But if you want me to reach out, I can lean forward too. I think we should probably stage it rather than have a simultaneous assault, because it hurts people's feelings.
Kara, I'll step back
Okay.
because you're going to probably look for someone at Lori's, right?
I'll probably look for someone in DuPage, to be honest, because I think that there's receptivity to having a local representative, but I will try to find someone who's bilingual as well.
Okay, I'll step back. David, just for clarity, are we just going to survey those who registered for the last meeting, or are we going to incorporate teachers or school nurses or others who work with young people, children?
Well, we have a list in hand for the attendees so that we can get that out pretty quickly. I think it's all to the good to reach out to broader groups, that is, we can develop that standard message in the survey, and it would be just fine to get it out to broader groups. But my commitment would be at a base, we want to go back to the folks who were with us that first time. And my commitment, Jan, would be to get that survey language out to you early next week, Monday or Tuesday. And so for me, it would feel good if we do find a date that today feels good to everybody here. What about, let's see, 2, 3, 4, 5. What's May the 5th is a Thursday evening. And I wonder how that would look. And, or Mila, does that meet your 3-week?
I think we're looking maybe to look to the next week rather than the first week of May, to give people a little more time.
We're going to want to try and do the language interpretation and get some of the other tech stuff going. So I love that extra week.
Very good. So what about Monday the 9th? That would be the day after Mother's Day. All right, I'm not hearing objections. All right, good, thanks. Great discussion. And I want to invite the current funding opportunities. Kara, do you mind if I pull you up in the agenda on Public Health Navigator updates? That'll give me a chance to kind of clear my head from this discussion and pull up the next level.
Easy enough. Yeah, this is just a brief update, but can definitely move that through now. So I think folks have heard, but I'm not confident of this, that We received notification, as did all of the other currently funded pandemic health navigators, that that project, which had sort of been, it was unclear whether or not that funding would continue past June 30th, but we received confirmation that in fact it would end on June 30th. So for all of those organizations in the community that have been funded and tasked with pandemic health navigation, both to support families directly impacted by COVID, but also to support education and outreach efforts more broadly. That funding will be coming to an end on June 30th. In some portions of the state, it will continue, but DuPage County was not one of the 27 counties that were identified to have continued funding support for that project. There is another project which we've talked about here at Heart in the past that is still in conversation or in flux. This was a smaller grant opportunity intended to launch, intended to launch by now, very honestly, based on the initial timeline. But as is oftentimes the case, it's very difficult to stand these programs up as quickly as the state might wish to. But intended to go at least through the end of December, I think potentially with a no-cost extension where that deemed appropriate. This is a hyper-local outreach effort that has specific zip codes identified for more targeted outreach. This is not around providing support for COVID impacted families, so it doesn't have the same resources attached to it, or for example, addressing food insecurity or helping people with materials and supplies or housing, et cetera, to help during their COVID recovery. It's more intended to support community outreach, addressing vaccine declining or vaccine hesitation, and supporting education. And I'm probably going to miss a zip code as I say this, so forgive me, but I can tell you the ones I'm confident are included. And that includes Addison, Bensonville, Wooddale, portions of Glendale Heights, and portions of Aurora. From a DuPage County perspective, other zip codes as well, but those are the zip codes that were identified in DuPage. And again, I feel like there may be one other, but I can't put my finger on it. This was a statewide application opportunity. A number of us on this call submitted interest to potentially partner on an application that IPHA and IPHCA were putting forward. And they received word and a request for budget revisions that indicated that they were one of several community-based organizations that had been selected for funding. The good and bad news of that is that it would reduce the funding somewhat significantly for that particular project, spreading it out across multiple funded organizations. But that's sort of a double-edged sword because it means that you have fewer resources with which to launch any particular project. Dave and I had some conversations with IPHA and IPHCA, thinking through how that might look and whether or not there could be a credible and successful intervention locally based on a few $100,000, $200,000 to $300,000 versus the 1.2 or 3 million that was initially available, and put forward some recommended strategies for their consideration and are waiting to hear back. I would say that it is not impossible, and this is my speculation, not communication from them, that funding partner could decline this opportunity because the resources are deemed too small to be able to launch an effective strategy across all of those zip codes. But I just don't know that. It's just that it's been silent for a few weeks and it makes me wonder. But my commitment, and I'm sure Dave's, would be to keep people informed with as much information as we have going forward. In the meantime, the DuPage Health Coalition has some funding from 2 other sources intended to support COVID outreach and education activities. So independent of whether the PHN project ends or whether the other project comes to fruition, we will certainly be continuing to do COVID outreach through those other funding sources. And I imagine we're not alone in that effort, thankfully. So that's the update that I have.
Hey, Kara, this is Chris. You've been so generous in sharing that information that doesn't seem to get out anywhere. So thank you so much for being open and transparent with what's transpiring, because it's such a frustrating process. Has there been talk at the state level so that the resource that is promoted to people who test positive is that link, and then the link to Pandemic Health Navigators for food assistance, rental assistance, transportation? Is there talk of that going away statewide, that June 1st date, or there would be some other resource and then these local efforts?
That's a great question, and one that I haven't heard an answer for, Chris, because if you're going from a statewide approach to a targeted zip code approach, then what happens in that centralized quasi contact tracing model for people that do identify that they need resources or assistance, and no one has communicated that to us. My presumption is, very frankly, that it in the 80 odd counties that are not included in the extension of pandemic health navigation, that it is sort of left to the county to fend for themselves or cobble something together, that a statewide approach wouldn't really make sense anymore. So I'm happy to pose that question because I'm quite curious as well. And I haven't heard.
Okay, thanks.
I unfortunately think this is another example of how policies are being shaped without the consideration of the suburban demographics plays out, because I think in rural Illinois, where entire counties potentially are in one zip code area, it probably makes sense. But in our area, I think that and then again, in cities, it tends to be, where you get, that kind of community or neighborhood center. But I don't think that works for suburban areas where we much more densely populated, but mobile, right? So yeah, but again, I don't think any of us had any influence, and other than Kara, who has been absolutely amazing with the advocacy and willingness to share our concerns. So echo that appreciation.
I wish it worked better. It was a learning exercise.
So do we for the first 9 months of trying to bang on IDPH. So
the other thing I'll say is that when I look at the vaccination rates of the zip codes that were identified in that hyperlocal approach, they certainly seem appropriate. I mean, DuPage County on balance is doing better than most, but those are the zip codes that have modestly lower rates of vaccination than others. Sometimes it's just a question of a few percentage points, but nonetheless, it's there. But notably, West Chicago's omission from that list does not make sense, because West Chicago's numbers are absolutely in line with the numbers of the others that were identified. And I very frankly find myself wondering if somebody missed something, that it was unintended versus intended, because I just can't wrap my brain around the disproportionate impact in West Chicago, coupled with rates that align with the others that were identified, and not having that community being included in this next step. So I don't get
it. Karen, would it, in the way in which they're pulling back, where there no longer is universal coverage with public health navigators coming through that state system, would it be wise for us to insert a countywide resource number into their system, so that instead of not responding or not being able to respond to people in West Chicago through the state system, there is a go-to place? And I guess that's my question is, would the health department be the place we want to get into their data bank to say, if you encounter someone with this issue, call here?
Yeah, I think support, although again, it is being scaled down. But certainly then potentially it would be the one number to call, and then we can reach out to the appropriate providers so that people don't have to know, again, kind of the whole reason for that public health navigator. They don't have to know the 15. I just think that makes a lot of sense. And Chris and Mila, do we still have a COVID line that's different?
We still have it. It's not, I think it redirects to our main number now. Double check. But we shifted a lot of that when the state moved to the one number.
Not putting Mary on the spot at all, and I mean that sincerely, Mary, just you don't have to respond to it. But just to say, as we think about community transformation, and we think about how as a community to respond to the potential loss of a resource, it might be an opportunity for folks to submit applications for that project that speak to this gap and propose some way to address that on a countywide basis that acknowledges the enduring endemic stage of COVID-19 and works to address the particular priorities that community transformation grants are intended to focus on in the application. So that's sort of an invitation for people to think about, perhaps.
I would agree with that. So it's not putting me on the spot at all. I think anything that really looks to address something on a system level, that's it has to be in those 4 areas: housing, food insecurity, mental health, and substance abuse. But yeah, that idea behind the transformational grants is exactly that. Let's look at doing something at a systems level.
All right, thanks all. Anything else that we should address on the issue of the pandemic health navigators and the shrinkage and the gaps being created? Then I'm gonna take us back to agenda item number 3, which is current funding opportunities supporting health equity. I want to share my screen once again. Many of you were with DuPage Federation a couple of weeks ago, a week and a half ago, when we had our Council Plus and Expanded group. All of the HEART members were invited, and we invited leaders who've been a part of our human services information sharing on COVID-19. We had a nice group of about 40 people who learned about 6 immediate funding opportunities that have a DuPage footprint. And they're different in size and scope. Many of the people on the call today were at that meeting. Many presented. So that's my first thing. Thank you to those of you who were there to share this information. I wanted to take a minute to debrief these 6 opportunities and ask the people who are here in HEART today whether there are any thoughts, reactions, or concerns that came to you as a result of this meeting. And then I want to raise up one of these opportunities for us to take a look at in a strategic way as an equity team and see if there are opportunities for us. So let me ask that first question. Many of you were present at that meeting. Any thoughts, reactions, joys, hopes that are coming to you as a result of these 6 opportunities? Oh, and I didn't really describe this. This is the agenda from that meeting. And number 3 is 2 opportunities. Item number 4 is 2 opportunities. Number 5 is 2 opportunities as well. Forgive me for not translating.
For folks who weren't present, number 3, the Milton Township and other mental health boards, is an ongoing but likely summer and early fall opportunity. The DuPage Community Transformation Partnerships, most are probably aware. There's an application due today for immediate needs, and then there's applications due in the coming months for larger transformational projects. For Edward Elmhurst Health, that application is due on May 1st. And the opioid settlement is was sort of an FYI for something coming down the pike, but no opportunities at this moment. For the appropriations and community project funding requests, the Senate requests were due last week. And then the requests for congressional, used to be known as earmarks, are due today and Monday, largely. So if you haven't done anything with this one yet, it's going to be tricky. However, there has been great transparency on the part of virtually all of the congressional districts in saying that they really have until more like the 22nd. And so if there was someone who was interested in submitting for consideration for community project funding and not able to do so under that timeline, what they would need to do is tell the congressional office and ask for additional time, which is likely to be granted up until the 22nd. And Mila, am I correct that the Hope Task Force funding has passed?
Yes, that one closed earlier this week.
Yeah. So a few of these are no longer active, but many of them still are.
All right, not hearing other reaction, I'd like to raise up for the group one of these opportunities that's quite alive yet, and I think has implications for our work. This is a slide from Colin Deloe of Edward Elmhurst, who presented on the Community Investment Program funding of Edward Elmhurst. This is a really significant funding offer. They're looking at $4 million to invest in the coming year. And although the time frame here is very short, there's a May 2nd deadline. I want to draw your attention to their areas of focus: health equity and the social determinants of health. And I want to put those into the lens of the work that we're doing, and dream a little bit with this group about what could we do if we looked for these funds to support our work as a health equity and access response team. And I can put three things on the table for us to think about. One is the community conversation. We have a very good sense from our January meeting that there's an appetite for that. And what we lack is staff support to operate the thing, to be a part of the construction and presentation of the event. And a grant like this would allow us to bring on staff who could manage a year of conversations. Second thought I'd put in your mind: we have had some fantastic data, original data work done and presented to this group regarding vaccine confidence and vaccine hesitancy. And that has been fantastic, coming from specific origins within our community. And that's another area that we could continue the work of building relationships of trust throughout the community if we had financial support to pay for the construction and implementation of those surveys and focus groups. Just a minute ago, we heard Sima talk about Kids for Kids. That's another place where if we had some staff support or could financially support staff support, we could present such an event. So I put that out there for you to think about. What do you think?
Dave, a question: when we say we, are we speaking of HEART as a group? So right now we sort of exist as a coalition with sort of staffed by all of our collective efforts, but this would be more like a dedicated staffing model for HEART.
It is. And so I've not had this conversation with the health department. Kara, you and I have had some brief discussions, but not in depth. But I think that DuPage Federation, DuPage Health Department, DuPage Health Coalition are all potential fiscal agents to bring the dollars in, to organize that so that they can get put to work.
Notably, the minimum investment for Edward, this is good and bad, more good than bad for sure, is about $250,000. So they're expecting applications for $250,000 or greater, which is not to say that they haven't closed the door entirely on smaller applications, but they've made it clear that their preference would be applications of that scope.
Understood. So my thought is we would want to think about what it could look like for us and have the conversation with them, put the request in front of them, and hope that they would see the value that this brings back for their objectives.
Kara, that's interesting that it's so high as a sometimes funder. It certainly makes sense from a logistical standpoint, but any idea about, did Colin talk about the types of, the scope of projects that they're looking for, or, what's your sense?
So I'm on the committee, the Community Investment Steering Committee, so I have a little bit of context from that. And I had the same comment to them. I think that for hospitals, please don't get me wrong, I think sometimes for hospitals, this seems like a smaller number, but for many community-based organizations, it's a large one. So I think it is about wanting to be able to, have projects that have the promise of a real return, like, that can, where sizable impact can be measured. And I also think that it is in part with their first year foray, wanting to manage the number of applications. Even with that number, if they were to fully fund, you'd be talking about 15, 16 applications at that number. So, 15 to 16 funded projects, which is still a lot. The other thing that I would say is, and this project for them does not have dedicated staffing right now. It's being supported by pieces of different Edward Elmhurst team members. North Shore has the same amount available in the north region of this newly merged health system. And they've already completed their funding cycle, and they only awarded $2.6 million of their $4 million. I don't know precisely why. I know that they didn't fund all applications that came to them, so it wasn't simply that they didn't get enough requests. And I certainly understand why an organization would decide about the quality of the requests or the fit for the applications. But it means that they're open to possibly not using all of that funding if they didn't believe that it was appropriate, in which case it would roll into the next year. It wouldn't go away. It would roll off to be available for future. I think they're also willing to consider multi-year applications. So you could potentially ask for that minimum, but spread it over a 2-year project, for example. That might be possible as well.
Kara, do you know if they're allowing for capital projects for this grant?
I believe they are, yeah.
Okay, thanks.
And they're focused on their primary service area, which is not all of DuPage, but most all of DuPage, certainly the northeast and southwest portions dominantly, but also small portions of, not small, modest portions of Will, and even some portions of suburban Cook could be considered as PSA for Elmhurst.
David, could we look at Impact DuPage and consider the seriousness of disproportionate health outcomes? And I'm thinking specifically for African-American women and breast cancer. And what would a call to action look like to get those numbers down? I've been working with a group of 3 of us and looking at, I guess we can call it causality. And when we look at, is it a difference in diagnostic approach? What are the frontline treatment options, genetics, clinical trial data, maintenance therapies, all of these things plus. How do we as a community address this? I mean, we are about the heart, health, equity, access, right? Should we be paying more attention to our numbers as we see them with Impact DuPage, and how do we improve on, how do we target some of these areas to improve opportunities for optimal health outcomes?
Absolutely. Jana, one of my thoughts in response is that we can see by the size of this pool that this is one of those strange opportunities in our lives in DuPage County where it's not requests at a level of 100 and only $2 to spend, but there are a lot of dollars. So it's in our interest to spark as many conversations with Edward Elmhurst about what's going to move things to improve things. And I want to say that to everybody on the call. We're all working on advancing health equity. And I do encourage you to think about what's the project in your mind that you've been working on that would have value, and is there a way to get an application in front of them to start the conversation?
Hey Dave, I don't
yes.
want to be the wet blanket,
Yeah.
but I am a pragmatic man. Heart is a online group of people who get together. We don't have a bank account. We don't have an organizational structure. We don't have corporation documents. So are we eligible to apply for this money? And if so, who would be the vehicle to do that through?
We would need to have a fiscal agent, and it would have to be one of us.
Okay. Then I would look to you. Is there a volunteer to do that? Someone willing to take up this mantle, and then we can give ideas, because otherwise we're just a bunch of people in little boxes on a computer.
Well, my thought, Evan, is that DuPage Federation is willing, but this is a conversation for us to have with the Health Coalition and the Health Department to see what's the best fit. We have a great collaborative relationship, and we'd come away with the best idea for where that infrastructure should be.
Well, with that hurdle, with getting over that hurdle, then I think the sky's the limit. I come from a world where we deal in tens of millions of dollars for projects. $250,000 I could spend in my sleep. You know, we get a couple people working for us and give them a program budget. We're well over $250,000, and you say I can do it over multi-year. I mean, let's go for it.
And I would
That's the
say that
vision
for
we
those of
need.
us on the call, if we're anticipating applying for something that is specific, the place where it gets tricky is having to measure out the application that you might submit on behalf of your organization and the application you might submit on behalf of Heart. And I would think that what would be appropriate then would be conversations for DuPage Federation or DuPage Health Coalition, even the health department, that would say, would we disadvantage one application by submitting two? Because then you have to sort of manage your conflicts.
There is the other role we could play in that then, which would also just be to throw our support behind one of those applications.
Absolutely.
I think it's a really exciting opportunity.
I think Simon's asked a really good question. Is ICNA relief a part of Heart? And my answer to you, Simon, is that yes, all participating members are a part. We have three kind of organizing members. It's the Health Department, the Health Coalition, and DuPage Federation that kind of conceive the idea and feel a responsibility for the support of it. And we're very grateful to Health Department and Mila for being our backbone to make sure that meetings are scheduled and that we come together. But Heart is all of this entity here, all of the members who are here.
Chris and others, has anybody seen anything that would suggest, Mila, to I didn't look at the application process through Edward Elmhurst with an eye to thinking about whether a public health department would be a qualified entity for application. Because there is certainly the consideration of whether the health department might submit an application that would fund in the same way that we're talking about for EHC or DuPage Federation or ICNO or any of the others.
I hadn't looked at it in depth yet, so I'm not sure.
I didn't look at that criteria, Kara, but it is a really nice funding opportunity. So I'm sure there will be a lot of interest.
I would hazard a guess to say that they would, I mean, I do think, I'll go back and look and see what I have. It feels like they would want to say yes, that they would want to be able to include you as a potential funded applicant. But I don't know if they've done anything that would explicitly preclude it. Actually, wait, take it back. I know that Lake County Health Department applied for North Shore sort of through their FQHC model, but nonetheless, it was the health department. So,
and Kara, I don't remember the catchment on that. Is it full county for DuPage or I don't remember.
Ish. Most, I mean, you don't have to serve every piece of their PSA. Clearly, they're prioritizing their PSA, primary service area, and but so much of DuPage County is included in their primary service area. So I don't think that would be conflicted.
Thank you.
Mimi, you're asking about a link to the opportunity. I'll send it to everyone. I'll send the follow-up email we did after the DuPage Federation meeting a few days ago, which has all those links so that you'd have access to all of them. And you know, my thought is about our role is to make sure that the best ideas are getting in front of Edward Elmhurst to have an impact. And I think about the things that we've been doing that are niche things that aren't being done elsewhere in the community. That's why I think we're potential candidates, but really we want to encourage the best solutions to get in front of them, regardless of where they're coming from. And this is one of those rare opportunities that I don't know when I've experienced this in my life, where it doesn't appear there's a limit. We don't have to be parsing or deciding whose application is the best because there's so much room in there to do so much. At least it appears that way right now. We don't know what all others are thinking to put in. So I guess that would be my big message. We want to be encouraging good applications to go in to address equity issues. And I think our activities are a part of that. It would make sense for us to put in an application and have a conversation with them, even if we don't hit the $250,000 mark. So here's my thought. We're at 10:16. I'd like to move us to the health department update, Chris. And regarding funding, I'm not hearing a consensus here. I think what I would like to do is launch a conversation with Kara and Karen about potential application on behalf of HEART, and then put an idea out to you all about what that could look like, and online have a conversation in the context that we're not looking to compete against others so they won't get it. We want to add value, and there doesn't appear to be any limit right now to the value that can be added.
Yeah, I think it's great if we all apply together, because it will definitely show the unity, and always, you know, if you are together, there's more chances. So definitely we're for that. But for me, for particularly ICNA relief, you know, we have so many different type of needs, and we are at a very low level. You know, you will have development department, maybe you have grant writer. We have nothing. It's just like few folks who are doing so much and trying to. So if we are looking for funding, we have so many itty-bitty needs, which might not interest the HEART, but we would definitely want to be part of this group and want to be, part of that funding, of course. But at the same time, there are some other needs which, if we can apply from this team, that'd be great because it will lower my workload. But if it is, if there is no interest in those areas which are needed for ICNA relief, then I think it's okay to apply, from as an independent organization and as a work group, right?
Very good. Very good. Thanks, Saima.
And I
know
will
I'm
say that I know that Edward Elmhurst has indicated that they would welcome collaborative applications, certainly.
Yeah.
And that it would be possible to participate, as I recall, in a collaborative app. You're not barred to one application. So if a particular agency or entity had an application that they wish to submit on their own behalf and separately wish to join another application, I don't believe that that's disqualifying in any way.
Got it. Okay. Thank you.
All right, thanks all. And Chris, with apology, we have 12 minutes remaining. Would you provide an update?
I'm happy to fly and then post it in the chat for everybody. I think the value is trying to centralize some of this information because, like Karen said, and you all know, that it's getting harder and harder to pull all the disparate strands of information about what COVID looks like together now. So let me pull this up and make sure you can see it. Okay, can you see the presentation, Dave?
Not yet.
About now.
Good, good. And Chris, one introductory comment, this is going to be for me one of the most important presentations you've done. This is a time when attention has shifted elsewhere. It's so much more difficult to pay attention to what we need to be doing in a community. So I appreciate you doing this.
No pressure, huh?
Right.
Yeah. And Liz Murphy, who's our Assistant Director of Communicable Disease, is on too, because we've been able to pull some new and updated data on the racial and ethnic breakdowns of cases and hospitalizations just over the past 3 months as compared to the whole pandemic, to give us a better sense of what's going on. So we're going to spend some more time there. I'm going to just flash some things at you so you know that they're there, recognizing we only have 10 minutes. So I will put the whole file in the chat as soon as we're done, and happy to take questions if you see something you really want to know more about. So starting here with the overview, we are in what CDC classifies now as low community transmission. Remember, they shifted to 3 new levels back in March that looked to put the impact together of new cases along with hospitalizations as an important indicator of how severe the impact on the health system was. And I think the most important thing for you all and us to know as advocates for individuals in the community is that these community levels are really helpful to know how bad the strain is on our health system today. It's not a great predictor of what it's like for an individual and their risk, or what things could look like in 3 weeks. Because by the time you get to medium or high level, we're starting to see some really significant impacts on our health systems. So CDC's community transmission is based on the number of new cases in the past 7 days, the percent of staffed inpatient beds in use for COVID patients, and the number of new admissions per 100,000 over the last 7 days. So we're in the low level for all of those. We have less than 200 new cases per day per 100,000. We have less than 10 new COVID-19 admissions, and less than 10% of staffed inpatient beds are for COVID. That's amazing and fantastic. However, we are seeing rises in new cases. We're seeing rises in positivity, things that in the past would tell us, hey, we need to start paying more attention now and helping people look for the tools that they can use to protect themselves before we get to a point where hospitals are seeing a really big strain and we're almost too late to limit exponential growth in new cases. CDC's recommendations are here. We can come back to these, but I think hopefully people are learning the steps that they can take regardless of what the official recommendations say. We know that COVID spreads through the air between people who are infected, whether they have symptoms or not, and the risk goes up as you spend more time in close contact with people indoors with poor ventilation for long periods of time. So we have tests, we have masks, we have better ventilation, all things we know that we can do anytime, not just when CDC says, well, now's the time you should start wearing a mask. So a reminder that people can wear masks whenever they want. This chart shows the case activity across the country. I like this one a little bit better because it shows you just the number of cases per 100,000, less about grading you on a level, more about quantitatively how much spread is going on. And you can see that there's a lot more activity in the Northeast right now. And so watching Illinois carefully because we're creeping up on new case activity. Our own cases are much, much less than they were back in January. But you can see on this one that in the past 2 weeks, we've seen a steady increase. And yesterday reported over 300 new cases being reported, which is the most we've had since February, and a concerning trend if it continues. The last day is always incomplete because that's half a day's reporting. So when we update numbers for today and on Monday for the weekend, you'll be able to see this trend a little bit more clearly. An interesting thing we've seen over the past month, really, last couple of weeks, is that the 40 to 59-year-old age group has jumped to the top of new cases being reported, which has not been the case at any other time in the pandemic. We have very much been led by youth 0 to 19, 20 to 39-year-olds over the past year or so. Now we had spring break in there, so there was a lot less testing going on. People were either out of town or traveling or not being tested at school. So we're going to watch those really carefully and see what happens as people come back to school. Anecdotally and through our reporting, we are starting to see more cases being reported at schools, more clusters of students and staff who are turning positive, likely associated with that spring break travel. So this is a really interesting time, and we're going to have to be very cautious to see what happens. Here with cases, and when I get into deaths, we've got more data, like I said, that's been broken down to look at just the past 3 months. So I'm going to turn it over to Liz to highlight what we've been able to pull together and the significance of those.
Sure. Thanks so much, Chris. So the top figure shows that throughout the pandemic, so for our 211,000 plus cases that we've looked at, we broke down those case rates by ethnicity. So Hispanic or Latino versus non-Hispanic or Latino. And then in the gray, you've got DuPage County case rates overall by those different age groups. So when we're looking in the pandemic as a total across all those age groups, except those 0 to 9, the COVID-19 case rate is higher among Hispanic or Latino DuPage County residents compared to non-Hispanic or Latino DuPage County residents. The graph underneath shows that broken down for just January 4th through April 4th. So just the most recent 3 months and capturing the bulk of the Omicron surge. So again, we see that across all age groups, the COVID-19 case rate is higher among Hispanic or Latino DuPage County residents compared to the non-Hispanic or Latino DuPage County residents. So very similar what we're seeing more recently compared to what we were seeing throughout the pandemic as a whole. Oh, sorry, you can go to the, thanks, Chris. All right, so now we're looking at those data, again, top looking throughout the entire pandemic, bottom looking at January through April, broken down by race in categories of Asian, Black, White, and then in the gray looking at DuPage County overall. So in the top, across all those age groups except those 10 to 19 years old, the COVID-19 case rate is higher among Black DuPage County residents compared to White and Asian DuPage County residents. When you go down below, across all those age groups except 0 to 9 and 10 to 19 and 30 to 39, so there are a couple more age groups when you're looking at more recent cases where you see different trends. The COVID-19 case rate is higher among Black DuPage County residents compared to Whites and Asian DuPage County residents. But in those 0 to 9 and 10 to 19 year groups, the COVID-19 case rate is higher among Asian DuPage County residents. For those aged 30 to 39, the case rate is actually highest among White DuPage County residents. So a little bit shifting of trends when we look at the data broken down by race. And next slide, Chris. I think it's back to you actually for a little bit.
Yeah, I'll hit a couple other and then we'll come back to Liz for analysis of the death rates too. So an important note about positivity, based on CDC and state guidance on reporting for labs are not reporting negative rapid antigen tests anymore. So it's going to change how positivity is reported. because positivity will now only be reported for lab-based PCR tests. So it's going to change how these numbers are reflected. It'll still reflect positive cases out of all, or positive tests out of all lab-based PCR tests run, but it won't include those rapid tests. And that's partly to simplify the reporting for these point of care testing sites. So this data is only through April 6th. CDC website has some more updated positivity data that reflects those lab-based tests. So we're going to be looking at changing ours. So just to note that this could be changing, but we are seeing an increase in positivity over the last few weeks, and that's reflected in our data. It's reflected in the CDC data. We just found that Walgreens is now posting state-by-state breakdowns of their positivity data, and it's really alarming. Illinois is now at 16% positivity based on Walgreens site reporting. So we're definitely seeing an increase in those tests.
Chris, real quick, Chris, I'm sorry. How do we, if we are accounting for home testing?
We're not accounting for home testing now. There's not a requirement that home tests are reported. And there's not a mechanism to take that data in because it's a voluntary reporting system. You know, who knows what you're going to get, who decides to report those things. So we would 100% encourage people who are testing positive at home to notify their healthcare provider or seek, go through the FQHC or another health system so that they can either get a confirmatory test or that their provider knows they're positive and can act on treatment or other interventions. But the home tests are not reflected in our case counts.
Is there any tracking of data for the number of home testing kits that are sold or distributed by county or state?
Not that I'm aware of.
Okay, thank you.
Yeah, it's a good question. And it has a huge impact on our official numbers. And it is, Karen kind of said this, from a public health, we want good data. We want great data. We want all of it and really be able to turn it back around. For the community, we want you to have rapid access to testing and to know what to do with that and be able to get linked to treatment. So we're both frustrated and supportive of a shift to make this more accessible to people, but it sure complicates reporting. In terms of variants, we're seeing 100% Omicron now, and the pink bars on the bottom show that BA2 or the stealth Omicron that you hear so much about. And you can see that since February, the percentage of samples that have been reflected as that BA2 has grown tremendously, and that's likely what's driving our current kind of increase in new cases. Hospitalizations, much lower than they have been, really encouraging trends there. We've seen a little bit of an increase, but only single digits. We were at our peak back in January, close to 500 people being hospitalized each day. We're at 25, so much better. But watching this closely over the next few weeks to see if cases unlink from hospitalizations a little bit. When we look at deaths, similar thing, they're way down. And we've had several days with 0 deaths and really hope that that continues. Vaccines are working to prevent those severe illnesses and severe death. And Liz, here's the death data.
Thanks, Chris. So again, similar to prior slides, at the top, we break down deaths over the pandemic in its entirety. So for the 1,809 deaths that were reported, and these two graphs are looking at ethnicity, with the bottom graph being looking at the 155 deaths reported between January 4th and April 4th. In the top that you can see, if you look all the way over to the right at the total all ages breakdown by ethnicity, you can see that it looks like that the overall Hispanic or Latino case mortality rate due to COVID-19 is less than what you see in the non-Hispanic or Latino population. But when you break it down then by age group, you can see that at each age group, it's higher. That apparent discrepancy between the aggregate death rates versus that comparison by age group may be explained just by the demographics of the Hispanic or Latino population in DuPage County skewing younger than the non-Hispanic or Latino population. One thing to note in the bottom mortality graphs, and you will see this in the race version as well, we had a small number of reported deaths. And so when you break it down by by ethnicity or race, and then also by age group, we have sample sizes that are so small that in order to protect the statistical reliability of the data, as well as individual privacy and protected health information, we have to suppress those values for some of those groups. But we do still have some of the total all ages information. So for that bottom graph, the overall COVID-19 related death rate was lower among Hispanic or Latino residents compared to non-Hispanic or Latino residents. We had to suppress those other age group categories, but each age group category for Hispanic or Latino DuPage County residents had less than 5 COVID-19 related deaths during this reporting period. So we weren't able to make those comparisons. So just wanted to put that out there as well. That's one of the challenges when we start to look at those smaller timeframes. For race, in the bottom, there are a couple of groups that we didn't need to suppress when looking at those 155 deaths. So in the bottom graph, the COVID-19 related death rate for Asian DuPage County residents aged 80 plus years is 1.5 times higher than white DuPage County residents in that particular age group. So Chris, that's just the overall look at overall and then the more recent data. So I'll turn it back over to you.
Thanks, Liz. And Dave, as the facilitator, I'm going to turn to you and say, do you want us to stop here? Do you want to add anything for people that have to go and we can post slides? I'm happy to keep going. I don't know about Liz, if she's got a few minutes to take questions. We're happy to keep going, but want to respect the fact that it's 10:33. So just looking to you for some direction.
Thank you. So do you mind stopping your screen for just a moment, and we'll look at the group and kind of take a sense of the group. For me, this is helpful, and I would like to continue it. So extending another 15 minutes or so would be a good thing, but let me check with others. We're now down to a smaller group, and maybe I should just ask Evan and Mimi, Kara, Jan, and Saima. Okay, so Chris, please continue.
Okay,
Thanks.
well, we've got Liz. Do we want to pause for questions for Liz? Anybody have questions about this data or the presentation that she's just highlighted? That's the new data.
Liz, I have a question. I've been doing some reading about the challenge of reporting Asian data, as there's such a wide range and variety of folks. Do you have any sense? This is the first time I will have seen something that said Asian damage harm is greater. Do you have any sense of what's going on there and how that relates to our population in DuPage? I really don't know how to frame the question.
Sure. I think it sounds like perhaps you're looking for what our thoughts are related to a possible underlying explanation. I unfortunately don't have one. So in terms of the information that we capture, it is based on the categories in the state of Illinois surveillance system, because that's the surveillance system that we use as we investigate our COVID-19 cases. So we use their breakdowns, recognizing that there is a wide variety when you look within those groups at different populations and how they're categorized. I think one of the challenges in terms of trying to better understand that is that it's great that we have a small number of deaths. That's what we want to see. But when it comes to analysis, then that makes it challenging when we're looking at smaller timeframes to draw conclusions and to really understand the magnitude of those disparities that may be existing. So I think, we'll continue to review the overall death, the overall mortality rate as it's broken down by age group and by race and ethnicity as well, to keep working on addressing the disparities that continue to persist in those particular figures.
Thank you.
Thanks.
One comment, you talked about the age distribution, and I think that concept is so important for us to grasp, and it would be worth all of our while to spend time thinking about how we talk about this with our neighbors so that they understand, so that it's accessible to them. The results are incredibly disparate, but you have to understand how the age cohorts match up to total population numbers. This is
Yep.
really helpful, really helpful. That's what I want to say.
Good. I'm glad it's helpful. And yes, excellent comment. And one that, of course, confused us when we first looked at it just overall before you break down by those age groups. So yes, thanks. Such a key thing to remember.
Any other questions for Liz on those? Okay.
No, just echoing thank you. This has been a question that a number of us have sort of been wondering about for a while, whether looking at the data in aggregate obscures changes that are happening over time.
Mhm.
And in most respects, it looks like it does not, although there are a few outlier elements. But knowing the answer to that question allows us to know how to continue to provide useful intervention.
You're most welcome. Happy to help.
Thanks, Liz. And these will be in the full slide set so people can pour over these a little bit more and reach out with questions or other ideas. Shifting to vaccination and other resources now, CDC continues to update the outcomes of vaccination status on infection, hospitalization, and death. And it's just continues to be remarkable. I'm really blown away personally when I look at this and go, vaccines have a tremendous positive impact. And we need all the help we can get to take a scientific breakdown of this data as this slide is and turn it into something that will resonate with people and will help show them that these vaccines really do work tremendously. The chart here, the lines show the death rates by vaccination status. And so the black line is people who are unvaccinated, the dotted line is people who are vaccinated with the primary series only. And the dark blue line is people who are up to date with a booster. And this would have been just a single booster. This is before the second boosters were recommended. So even people who are just fully vaccinated and not up to date enjoy tremendous protection from death from COVID-19. And you can see that drops even further for people who are boosted. The summary on the bottom is that unvaccinated people age 12 and older were still 3.5 times more likely to test positive. So I think we hear a lot about well, vaccines aren't even protecting infection. What's the point? Why should I even get vaccinated if it's not going to protect me from getting sick? The fact is it does protect you. 3.5 times reduction in infection is pretty good. It's not as great as it used to be, and that's an important fact to acknowledge. But it really protects you. They really shine when you look at hospitalization and death. And so when you can show that people are 21 times more likely to die in January, those who are unvaccinated, that's a really powerful outcome. There are not many things that we can do to reduce death rates by 20% or by 20 times or greater at other points in the pandemic. So we really need help to convey just how powerful these vaccines are. Same thing when you look at hospitalizations. In February, this is data through the end of February from CDC, people who are unvaccinated in every age group were at least 2.2 times more likely to be hospitalized than people who were unvaccinated, or for people who were vaccinated and boosted. And I think that's important to show, even for the 12 to 17-year-olds, there is a higher risk of hospitalization if you are not vaccinated. And so I think we hear, well, it's not a huge impact and kids aren't likely to get sick. Absolutely true that kids get sick at a lower rate than some of these other groups, get severely ill at a lower rate. But if you're unvaccinated, there is a higher risk across every one of these age groups, and it goes up with every year of life to the point that people who are unvaccinated and over the age of 65 were 9 times more likely to be hospitalized in February. Since the last time we've met, and you all know last week or now 2 weeks ago, CDC and FDA expanded the recommendation for boosters, now recommending that adults who are over 50 years old may get a second booster because of that waning protection from those vaccines and the benefit of being boosted, really returning a higher level of protection to you. Those graphs show that even a primary series is pretty darn protective, but if you can get that extra protection that the booster provides, especially for adults who are older and at higher risk or with underlying conditions, that does provide a tremendous benefit. So this just highlights the changes and who's now eligible for those second boosters. We're at 77% of our total population fully vaccinated, almost 82% of those who are eligible. So again, for all the hate and distrust and hesitancy that we hear about, 82% of our population has voted with their arms, as they've said, and gone out to get vaccinated. And I think really highlighting that and norming the fact that people are getting vaccinated, getting this protection, and that it has shown to be safe. We're not hearing horrible stories about people dropping like flies across DuPage who were vaccinated. Just the opposite. We're seeing people who are not vaccinated, unfortunately, seeing some of these really severe outcomes, and we want to help extend the protection to them.
Chris,
yeah.
Do you mind if well, maybe I could do it with this next slide as well. I want to ask you about fully vaccinated and how we think about that and define that. Could you talk about that?
Yeah, it's a great question. So fully vaccinated still only applies to your first 2 doses of an mRNA vaccine, the Pfizer or Moderna. So people who have 2 doses are considered fully vaccinated. People who've received the Johnson & Johnson are fully vaccinated with 1 dose. Now, there are recommendations out there to get boosters, and to be up to date depends on your situation. So I could be up to date right now with 1 booster. Somebody with an underlying condition like, a chronic liver disease who's 80 may have 2 extra boosters, and sometimes 3 for severely immunocompromised people. So it's really affecting our ability to report well on vaccine status, because it's really hard to know when you look in the aggregate, this person has 2 shots. Are they up to date or not? And it's really complicating I think the ability to tell and show how much protection those provide. So it's a really good question, Dave.
Thank you, Chris. For me, that's the important thing, that we want to be aware that fully vaccinated today is a term that doesn't help us get clarity. It's good. We want to see it go up. We want to see it continue to rise, but we don't get clarity exactly.
Yeah. So for 5 to 11-year-olds, this is the group that was most recently made eligible. We're at about 50% of those kids are fully vaccinated based on the definition of having at least 2 doses of Pfizer vaccine, which is the only one that they're eligible for currently. And so we've done a tremendous job, I think, as a community getting this group some protection. It will help reduce infections. It will absolutely prevent severe illness in these kids. They may be less likely to have severe disease, but kids can get sick, can be hospitalized, can die from COVID. And so these vaccines do provide important protection. On the boosters, this is where we still need help. Honestly, we're sitting at about 56% of our fully vaccinated population has gone on to get a booster. So, I recognize the communication about boosters is kind of fuzzy, and people feel like, well, do I really need it? Why do I need it? When do I need it? But we want to make sure that people who have gone through the trouble, especially of getting fully vaccinated, recognize those boosters are beneficial and go out and get one. This improves over the age ranges. So look down at that last row of people who are over 65. 82% of them have received at least their booster dose. And this data will probably change again now that people are eligible for second boosters. There'll need to be a way to update those. But we really do want people to know those boosters are important, and we could use help spreading that word. In terms of reducing transmission, I think, Dave, this is the second half of why this is so important to talk about now is, we're seeing these cases go up, and I feel like there's this apocalyptic or, throw up your hands kind of thing. Like, well, I don't know what we're supposed to do now. Like, cases are going up, but I don't know what to do. And that's crazy, because we have these amazing tools and we want people to be empowered to use them, to know where to get them, to feel like they should use them when they think it's appropriate and not be waiting for somebody to require them or tell them now's the time. So summarizing the 4 kind of key things right now: vaccinated and boosted, self-testing, or getting a test somewhere else if you can't or don't want to do it at home, improving ventilation. This is going to be a huge key, I think, especially as the mandates and requirements go away, is improving these systematic changes, like improving ventilation, that, it doesn't matter if the person chooses to wear a mask or not. If it's well ventilated, we're reducing risk without anybody needing to take a personal step. And then using masks to slow the spread of COVID. So in terms of vaccines, we are still going out to do mobile events. We have our clinics at the health department. Health systems are still offering. Retail pharmacies are still making vaccine available. We have seen an increase in the number of people being vaccinated based on that booster recommendation. So it's good to see that number go up. But we still want to be moving to get people who are not vaccinated at all their first dose, their second dose, their booster. So happy to work with anybody on making these opportunities available. In terms of masks, I think really helping to communicate to people that masking is really important. And the most important thing is having a mask that will actually protect you. So moving up from a 1-layer gaiter that you throw over your face when you run into the store up to something that provides more protection, like an N95. So there's some great resources here. I put the English and Spanish links there, trying to help communicate the benefits of these and what provides more protection higher up the list. The feds have added a locator for free masks. So back in February, I think they started shipping N95s to pharmacies and other FQHCs and other locations. They were really hard to find, even for myself. I tried to find them to see where they were. And so I think this tool should be helpful. It does lay out what stores have them. You've got a link here. Feel free to share this in your communication. We'll be posting this on social media through our channels. But we want people to know that they can go get a free mask, a good mask at any of these locations. At-home tests, the feds opened up a second round of at-home test ordering. So if you have clients or partners that didn't know they could order or maybe waiting on it, or they ordered one set already, you can order a second set of 4 tests. It's not a panacea, but it's another option, and they show up at your house without you having to do anything other than filling in an online form. So a good reminder to really take advantage of that. We also just requested about 1,000 at-home tests to distribute through HART, through DuPage Health Coalition, through PADS. And so if you want some of these to distribute to your clients, your partners, we have them. And we'll send the resource request out to you guys after this meeting. But it's just a simple form. Tell us what you want, how many. We also have KN95 masks that we're happy to put out. We want to keep pushing these. So if you feel like at any point you feel like, man, we could use some more of those, call us, because we likely have a channel to be able to get them and then turn them around to you. We are continuing to operate our testing sites in Villa Park and the fairgrounds. The state closed all of the state-run community-based testing sites at the end of March. So if you have folks that may have been using those or relying on those, we're going to continue to run our sites that offer PCR testing, no cost, no questions asked, no doctor's order needed at those 2 sites. And they're running lower. We're seeing about 150 people a week. So much lower than days when we were seeing 600 people a day, but they are available and we want people to use them. So please share those. In terms of treatments, I think I shared these last time. There's some new fact sheets on how important treatment is and how important telling your doctor, telling your healthcare provider that you tested positive so that you can get treatment if you need it. And so English and Spanish versions here to be able to share. There's a new treatment locator, and you heard, I think since the last time we met, this test to treat program has sort of rolled out. It's bumpy. It hasn't been smooth. And early on, it was go to all these locations and you can get a test, you can get evaluated if you test positive, and you get treatment prescribed and walk out the door with a prescription. Since then, Walgreens has clarified that they're not actually doing this. You could get a prescription there, but they don't have a combined test, evaluation, prescription process. CVS appears to be the only retail pharmacy doing that. So this website, and I will add a link to this, will help you identify locations where you can get tested all the way through treatment in one-stop shopping. And then it also lists the locations that you can at least fill a prescription for Paxlovid or the other outpatient treatments, and ask your doctor to, or healthcare provider to prescribe there. And we have within 10 miles, 120 sites that can at least fill a prescription for those meds, 6 that can do testing, medical evaluation, and treatment in one visit. And that's all I got. So I'll send the slides out to everybody. Happy to take questions or point you to other data, but it is a tricky time. Case numbers are going up, positivity is going up. Now is a very important time for people to take steps to protect themselves if they're at higher risk, if they're concerned about somebody else in their family. Don't wait until CDC says, okay, now it's really high and hospitals are full. We want to empower people to protect themselves now.
What
Chris,
can you tell us about what locations, so for people who are uninsured with the ending of some of the federal funding for both testing and treatment for uninsured folks, where can we confidently assert that patients can continue to go for testing and or treatment without fear of a hefty bill or non-hefty bill, really?
Chris, you're muted.
Yep, sorry. 3 places. 1, our test sites through the county, that's being funded by those ARPA dollars. So we've made a commitment to keep those sites going. So Villa Park or the fairgrounds. 2, the FQHCs are still offering testing, and people can make appointments through them through the websites. And 3, the retail pharmacies, at least Walgreens and CVS, have committed to continue to provide free testing. I don't know how long that'll last. They've said they're going to do it for now, but they're still offering it. And then 4, I should say, is the state is still running the Shield testing sites, but there are none in DuPage, so it's not really helpful to us.
Chris,
Thank you.
is this about this kind of surge you'd expect to see after spring break? Do you think that's what we're kind of seeing?
Who knows? I mean,
Crystal
that's
ball
the,
time.
yeah, the $1 million question is, what's happening and how bad is it going to be? And every surge we've gone into, we've learned something. So I think we all expected that as mitigation measures went away and people were encouraged not to wear masks because it's quote unquote safe now, as people got back to more normal travel patterns, spend time together, I think it's pretty obvious that we would have expected to see more transmission. We know how the virus spreads. Those things all contribute to spread. We're seeing it. What we don't know, and I don't think anybody knows, is will those cases result in hospitalizations? Will they result in deaths? Some absolutely will. We don't know to what extent. Every wave we've gone through, people have said, well, this time we're not going to see cases lead to hospitalizations. They're going to kind of uncouple and cases aren't important anymore. Every surge to date, we've seen cases go up and then we've seen hospitalizations go up. So I'm praying and hoping and wishing that we see that hospitalizations stay super flat and we can more confidently say that, cases are going to continue, people are going to get infected, but we've got great treatments and great vaccines. Don't worry about it. I'm not ready to say that. And I don't think many people, smart, educated, wise people are ready to say that we're done with COVID.
You make a very good point, Chris. In that meeting with Dr. Pinsky, nearly everyone in that meeting said they are continuing to wear their masks when they're out in the public. And there's an immigrant store here in Naperville. I went by there yesterday and noticed that they have put up a new sign that says, please wear your mask in this store. So there is some concern and people are listening and watching. And I'm going to guess that pretty soon we'll start seeing more people seeking out the vaccine boosters.
I hope so. So making sure people know they're still available, the masks, the testing. Now's the time to get it, right? If you wait until the surge hits, it's going to be really hard to find stuff. So now's a great time to tell people, hey, you might not need these, but wouldn't you rather have them in your house today instead of waiting until, we're seeing lots of cases and everybody's out looking for these things?
Yes,
Yeah,
absolutely. I think we should have a very thorough disaster response and recovery plan in Illinois, especially in DuPage County. We are experienced now. It's not new. Being there, done that, we can do better. And a second thing is we should prepare ourselves on collecting the data of all the ethnicities and races. And third point is that we see in this current report that, Blacks and Spanish have more cases. So we should start working on those areas, right away, how we can minimize and, help those communities.
Absolutely.
It's really interesting. It's not surprising. We all do this, but, our activation sort of responds to the crisis instead of anticipating it. And we had record levels of people getting vaccinated in January at the height of Omicron, and I'm grateful that they did, but the truth is that their protections from Omicron were pretty muted because of the period of time it takes from vaccination to efficacy. Probably by the point at which they had real protection, Omicron was already fading. So it's really, I really wonder about whether or not we should consider some PSA messaging that really drives home the idea that it's during the lull that boosters and vaccinations can be most powerful. We are learning now that this ebbs and flows with some predictability. And unfortunately, we as a society don't appear to learn a lesson from that in terms of how we respond to those waxes and wanes. We wait until it crests and then we react. Doesn't help as much.
Yeah, we know trying to stand up a testing site at the drop of a hat is impossible. So it's better to have it and have it available. We know that getting masks out, takes time, getting tests out. So yeah, whatever the message you think is helpful to tell people, take time now. And yeah, Jan, fear is a great motivator. And, we've been accused of scaring the heck out of people. This is something that's not real. we need to balance that message with, you know, we may be in a great spot a month from now. We may look back and laugh that we were worried today, but I would much rather take steps to protect myself, my family, my friends, and helping people to take control, right? We know that when people don't feel like they have control, they're more anxious, they're more worried. Here are some things you can do today to protect yourself. And here's the places to get them for free. Here's the places to call. We have them, and we need your help to get that all out. So anything we can do, happy to help.
And that's why that perspective from that Seattle King Flyer about, consider this, someone may have a, unvaccinated young person or person at home. It really, I think, creates some thought about how we're going to learn to live with this and be considerate of risk factors and think about those risk factors for behavior.
Yep.
Chris, thank you for an incredibly comprehensive report. Recent data. Liz, thank you also for that.
Yeah,
and
thanks
also
to Liz and Dr. Chug and her team for pulling that all together every day. They're updating numbers.
You've also given us our lead messages as we lead this meeting and communicate now with our constituents. That the slide about what you can do, the empowerment slides are really important. That's going to be my highlight in the message. It'll be going out to the human services information community. Thanks so much for this. Cutting through all of the uncertainty, there are specific steps we can take. Thanks all for staying on. It was very worthwhile to do this. Chris and Elizabeth, thank you for taking the time to stay with us past time. Thanks all up to you for what you're doing. I'm going to bring us to a close unless there's anything else that we should attend to. And I wish you all a blessed weekend and whatever that tradition is that you'll be celebrating. And I wish I could bring all the greetings to mind right now as we close. But it's a special time. And I wish you safety and rest.
Thanks. See y'all later.
All right,
Thank
take
you.
care.
Everyone.